Hey, thank you, Eduardo, and good afternoon, everyone. Zeeshan Sardar, I'm one of the orthopedic spine surgeons here. Um, Focus on seeing patients primarily at the Allen, at our new office in Hudson Yards, the Spiral, and also in New Jersey at Tenafly. Just like Eduardo said, pretty much all of us treat most spine patients. I don't really treat little kids, but adolescent to adults I treat. Hey, thank you, Joe and Eduardo, for the talks. So I'm going to focus specifically on adult spinal deformity, how we are optimizing these patients, how we're getting them ready for surgery, so less of an AI model there. But then I'll talk about how we're using patient-specific planning to really execute the plan. And here are my disclosures. So I'll start with the case example. This is a 53-year-old female who came to me with quite significant deformity and disability related to it. Here are some of the concerns. This is unfortunately not an uncommon thing that we see in some of our adult patients who have been going through pain for many, many years. And so she was on Vicodin a few times a day. She was taking methadone. She had osteoporosis, but was not treated at the time she saw me. And she was also a smoker. Now, she had undergone a lot, again, years of non-operative treatment, including different types of physical therapy, massage therapy, injections, medications. And at the bottom, you also see her grip strength that I typically get in all my patients just to get a rough idea of their overall kind of strength status. And so I'll come back to that case at the end, but that just kind of highlights that these patients that are coming to us for surgery, it's not just about the spinal deformity itself. They're coming with a lot of other aspects to their medical condition that need to be optimized. And so we have done a lot of work in this field, specifically in terms of optimizing the patients prior to surgery, getting them ready before surgery. And so we published the biggest thing that we have been working on for our patients has been the treatment of osteoporosis prior to surgery. And so, most of my patients will get screened. Pretty much everyone gets screened above the age of 50 to see if they need further testing for osteoporosis or not. And those who do, they get bone density scan. We get a CT scan also to kind of look more closely at their bone density because we know that sometimes the bone density is not as good. And then for those where there's a concern for osteoporosis, they get started on treatment for many months prior to surgery so that the bone health is actually better before we even take them for surgery, because we can see a lot of issues for those patients are not optimized. We pay a lot of attention now to nutrition for these patients. We assess their nutritional status, and I'll send them to dietitians, nutritionists, if I see that they're malnourished. Sometimes even obese patients, even though they're overweight, they may be malnourished, and so we check these, we take these seriously. Again, we publish on this as well, on the importance of optimizing these patients from a nutritional perspective. Pre-op rehab has become a really important field in the treatment of these patients. The key benefit there is that it can really lead to improvement of their pain levels and functional status even prior to surgery. And even though it may not cure severe deformity, I've had several patients who come to me as they're undergoing their pre-op rehabilitation that they just feel better, they feel stronger, they feel better, they feel more ready for surgery. They're still going to have surgery because they still have the disability associated with the deformity, but they're physically a bit more prepared for surgery. And this is what I tell all my patients, that you have to prepare for surgery like you prepare for a marathon. We don't just get up and run a marathon the next day. You got to prepare for it. So I try to get my patients to really get ready for this surgery for a few months, 2 to 3 months prior to having these huge surgeries. And so, this is kind of our summary of this. We published this as well, recommendations for basically practical steps to optimize all the different aspects of these patients prior to them having surgery. And my patients get this checklist that I kind of go through with them prior to surgery, which goes through everything from physical endurance, resistance, nutrition, even mental preparation, opioid medications if they're taking that, smoking, diabetes, bone health, family support, all the different aspects that I think need to be prepared and optimized prior to surgery. And then even before, when they come in for the pre-op visit, we go through this again to see which areas they were able to optimize. Switching gears a little bit, once the patient, we think from the other perspective is ready for surgery, then we start planning the surgery. And you guys heard a little bit from Dr. Lombardi about the use of AI in planning for spine surgery. The key benefit to my practice has been that you can actually make multiple models using AI to then pick the alignment that you think is going to work best for the patient. So we have published a lot in terms of the alignment goals for adult patients who are undergoing deformity surgery and which goals we think work best in which situation. And so these modeling softwares allow us to really pick the right model. We can model different things, and then we pick the one that we think is going to work the best. The next thing that's really been important in these complex cases and really executing the plan appropriately and as we planned it has been robotics. So I use robotics for almost all my adult deformity cases. And as you can see, especially in patients who have had prior surgeries, multiple surgeries, prior fusion mass, instrumentation, sometimes the landmarks, the usual landmarks, are quite distorted. And the patients can also have quite small pedicles, as you can see in this picture here. The pedicle where we put the screw is very small on this one side, and there's other instrumentation on that. So, with robotics now, we can really plan every single screw and try to plan the screws so we avoid even placing the screws where the rod already exists. And this makes the execution of these plans much more safe and much more predictable, because now we're able to place the screws even without known anatomic landmarks very precisely into where we exactly plan. And then coming back to how we execute the plan, as far as alignment is concerned, it's nice to plan the alignment, but you have to have a tool to then carry out that plan. And that's where I use patient-specific rods, even for degenerative cases, even for 1-2 level cases. We can, as you can see here, a patient with spondylolisthesis and collapse at L5S1. These type of patients, we plan the rod, we plan the alignment, and we plan the rod. And then using the planned rod, we can execute the plan that we had pretty close to how we designed this surgery to be. So this really adds that predictability now in our outcomes as far as radiographic and even patient-reported outcomes are concerned. Before we got these custom rods, before we could plan these appropriately, it used to be a lot of guessing intra-op, a lot of kind of gestalt, a feeling of, yeah, this kind of looks right. We would bend the rods intra-op without any true confirmation of things. And as we bend the rods, you also create notching, and so that creates the risk of rod fractures. But now we don't do that anymore. Now we plan the alignment beforehand. We make the rod according to the plan, and then we execute the plan. And then you can also use these rods to confirm that you actually got the alignment that you had planned for. Here's another case of mine, an adult idiopathic scoliosis patient that again we planned with these software, and we executed the plan as we had planned. Here's a good example of a patient where we kind of bring everything together: the pre-op planning, the robotics used, the custom rods, to really make a customized surgery for this patient. So here you can see I planned all the screws with the robot, and then I planned actually 2 different shapes of rods because of the deformity that this patient had. And you can see the pre-op to post-op execution, and you can see in this very right corner that this almost perfectly overlaps with the pre-operative plan that we had for this patient. So this really shows the power of how precisely now we can carry out these surgeries with less variation. The last thing in terms of patient-specific planning and execution is the use of now patient-specific intrabody implants. And what we can do is, in addition to the rods, we can also plan which discs we are going to clean out and which discs we're going to place intrabody implants at. And we can plan the alignment for those levels. And then we can really have an implant that's going to be designed to the shape of that specific disc itself. And on the left side here, you see an off-the-shelf implant. On the right side, you see a custom implant. And you can really see that the coverage of the bone contact is going to be much better with custom implants. And so that increases the rate of fusion, that increases or decreases the risk of subsidence of some of these implants. And the last thing in terms of this planning and modeling is the use of virtual 3D models. And as you can see, for complex patients like this patient with the spina bifida and head infant was placed in 1987, we can really create software models using a merge of X-rays, CT scan, and MRI scan to have a better look at the anatomy of these very complicated patients. And you can see the vessels here are really intertwined, and you could see in the back here that this whole area is basically the dura that's uncovered for these patients. So these type of modeling really allows us to have a better look at these patients before we operate on them. Now, coming back to our patient, the 54-year-old lady who was on high dose of medication and had osteoporosis and was a smoker. I sat down with her. We went through all the different optimization checklist parameters that I wanted her to do. And about 11 months later, she came back saying that she had stopped smoking for 11 months. She had been working with one of our physical therapists, so I did get updates in the interim as well. She was working quite regularly to improve her strength. She started taking medications for the osteoporosis, guided by us for the past 11 months. She stopped taking the methadone, working with her pain management physician. She was now exercising daily, walking for about 30 minutes, using ski poles and cycling for about 30 minutes and performing multiple stretches. And you could see a clear difference, even just in terms of her grip strength from the time I saw her to the time she comes back for her pre-op. So a substantial difference in her general condition and grip strength overall. And she is one of the patients who actually told me that, she feels a lot better. She still has issues. She has pain. She still stand up properly, but she feels a lot better. And so so we decided to proceed with the surgery because now she was optimized from all aspects. And this is her pre-op to post-op, showing really good correction alignment. And she was very happy and thrilled so far with the alignment that she has. And so key points is, all this starts before the surgery. We must optimize these patients and get them ready prior to doing these huge surgeries on them. And then every aspect of the care of these patients is patient specific, including the optimization, including the extent of surgery and correction they need, the planning of the screws, the alignment, the rods, the 3D models, interbody implants. Everything is patient specific, and all that is done to minimize the variability from the plan that we have created. So I'll stop there. Thank you very much again for joining us, and happy to answer any questions that you guys might have.